So our next presentation is from Dr. Balzaro and the group from Verona in Italy, and it's looking at can the anterior vaginal wall repair surgery influence the results of mid-urethral sling, long-term results with 7 years follow-up.
Thank you.
Dr. Balzaro.
Thank you very much. It's a pleasure to be here. This is my disclosure. So the aim of the study was to assess the influence of concomitant anterior vaginal wall repair in women candidate to middle urethral sling for stress urinary incontinence. So we had 76 women treated for stress urinary incontinence. Group 1 was just stress urinary incontinence because they had no prolapse. So we did the middle urethral sling. In group 2, they had also an anterior prolapse, so we did the anterior vaginal repair plus the middle urethral sling for incontinence. The anterior prolapse has been repaired by anterior colporrhaphy or anterior colporrhaphy plus porcine xenograph reinforcement apposition or polypropylene MS reinforcement apposition. We had the mean age was similar in the two groups as the Valsalva liquid pressure 2, number part day 2, but we had a majority of overactive bladder in group 1. This is the population, all the population with the pelvic organ prolapse, and you can see that the larger population was POPQ stage 3, 65.7%, that is the red color, and POPQ stage 2, 25.7%, that is the blue color. Someone was a 4 stage. All the patients had a preoperative urodynamic, had the workup before and later and after the surgery with the physical examination, stress test and POPQ, number of per day, urinalysis and voided diaries. And subjective outcomes were evaluated with the validated questionnaire, the global impression of improvement, and the patient perception of bladder condition. And a simple question, but not validated, that was, are you satisfied with the surgical procedure? Objective stress urinary incontinence failure was a positive stress test. So this is the result of group 1. There was a long follow-up, 76.5 months, 41 patients. The majority had activity O, 61%. And this is the result of group 2, a very long follow-up, 107 months. They had in particular, a majority had anterior colporrhaphy 51%, and almost similar group in the use of xenograph and mesh. And these are the population with the different prolapse. You can see they have the majority of POP3 stage. Here you have a little bit more of the POP3, no POP2, but more of POP4. And here we have no POP4. This did also the middle urethral slings, and if we make an amount, we have a majority of TVT, 54%, instead of TVT O, 46%. Objective results. We found our stress urinary incontinence recurrence major in group 1, that one with just a middle urethral sling, but we had no p-value. We have a trend, and probably major numbers could change this trend in a p-value. We'll see. I reported also recurrence resolution de novo overactive bladder. We were not able to avoid a statistical analysis here, and the number of per day were almost similar. We did a sub-analysis of group 2, and we found that the AC group had higher recurrence of stress urinary incontinence. We tried to find some possible explanations, but these are just explanations and theories, so no support, no scientific support. We thought that there could be a greater support created by a mesh or biomesh at level 2 of the Lancet, or a lower fibrosis effect that could create a minor pool of consequence and parietal tissues. But these are just suppositions. About subjective results, we found a higher success in group 2 with the PPBC and with the are you satisfied with the surgical procedure question, not in the PGI. So we had also some complication, obviously, and but with not different in the p-value. We had more poor in the group 2, and 2 patients had to make a tape incision of the TVT. In conclusion, concomitant sister cell repair does not influence middle Sling results, does not increase complication, does not increase stress urinary incontinence recurrence, but increase the subjective outcome, probably due to the fact that this patient had double problem, incontinence and the pelvic prolapse, instead of only incontinence. Thank you very much.
Thank you very much. And this paper is now open for questions.
Yes, please. Congratulations for the presentation.
Thank you.
Matteo, may I ask you, did you standardize the cough stress test before and after surgery? For example, did you repeat the stress test at the same volume before and after operation?
Yeah.
Thank you.
What I used to do is to ask to the patient if they leaks, first of all. Then I put the patient on the lithotomy position. I look for a leak. Then I put a catheter. I empty the bladder, and I refill the bladder with 200 and 250. And if she doesn't leak with 300, and I make her some cough, very high cough, several cough. So this is my standardization, but it's my personal standardization.
Maybe I could ask you a question. We're just looking at your abstract. The preoperative urodynamics, did any of these patients have detrusor overactivity? They had symptoms of overactive bladder?
Yeah. Some of them, they had detrusor overactivity before the surgery, but I didn't show the numbers. I'm sorry for that.
That's okay.
I don't remember even now.
And there's reasonable evidence now, isn't there, to show that if you repair a prolapse, a cystocele, that improves the overactive bladder symptoms. Is that something you noticed here as well?
If what?
When you repair the prolapse, so in your anterior colporaphy group, did their overactive bladder symptoms improve as well?
Yeah, that was the 23, I guess we had before. No, okay. We had the 23% of improvement in that group. So it was nice, and because they really would get better.
Philip Romano from UK. I didn't catch how did the patient were in each group. Was it just?
Oh, this
how
is
do you choose a group?
This is just a retroactive evaluation of patient that has just had surgery and the other one surgery.
And therefore, there was one group which was the more higher overactive patients. In one group, you said group 1 was more overactive bladder.
This is what we found retrospectively.
So there's a biasness in the group?
Could be, maybe.
Definitely, because one is more overactive bladder, one isn't. So.
Well, but the results are the same, so.
Do you want to introduce next? So I think if there's no more questions, thank you very much.
Thank you. Thank you for the